The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everybody. Thank you, everyone, for joining us for this webinar on sex and gender differences in treating asthma, COPD, and interstitial lung disease. This is brought to you by the Chest Foundation. And to start, I would like to first thank our supporters for making the program possible. That's AstraZeneca, Boehringer Ingelheim, and Genentech. I'm Ghada Bourjeily. I'm one of the moderators of the webinar, and I'm joined by Dr. Sharon Elliot, and I'll introduce her in a minute. But I want to say that this is something that we're very excited about. It's a really important topic, and you'll see, I'm sure you're all joining because you're interested in the topic, but we have three wonderful presenters today. Our first presenter is going to be Dr. Joe Zein. Joe is a physician scientist and assistant professor of medicine at the Cleveland Clinic, the Lerner College of Medicine. Joe's primary research interest is to study the effects of aging, gender, and sex hormones on asthma severity over the life course. He has studied the effect of lung aging on asthma severity and currently focuses on asthma genetics, population health, and healthcare utilization and cost effectiveness. Joe is going to be talking, obviously, about the asthma component of today's webinar. Next, we have Dr. Dawn DeMeo. Dawn is an associate professor of medicine at the Harvard Medical School. She's a faculty member in the Channing Division of Network Medicine and the Pulmonary and Critical Care Division at Brigham and Women's Hospital. She has had a long-standing interest in sex and gender issues and how they relate to lung health and lung disease. And she has been a recipient of multiple grants for the investigation of genetic and epigenetic features of sex differences and COPD. Our third speaker is Dr. Sonye Danoff, and Sonye is Associate Professor of Medicine in the Division of Pulmonary and Critical Care at Hopkins. She is co-director of the Interstitial Lung Disease Program, and she's Associate Director of the Myositis Center. She's a specialist in interstitial lung disease, and her particular focus is on autoimmune-associated interstitial lung diseases. Her research involves clinical and translational studies of interstitial lung disease and autoimmunity. She's a fellow of ACCP and past chair of the Interstitial and Diffuse Lung Disease Network Steering Committee. And like I said, I'm Ghada Bourjeily. I'm at Brown University. I'm associate professor. I'm at the Miriam Hospital here, and I am very interested in women's lung health, and I am immediate past chair of the Women's Health Network. And I'm sure we have a lot of attendees from the Women's Health Network, and I want to say hi to everybody. And next, I want to introduce Dr. Sharon Elliot. She is my co-moderator for today's session. And Sharon is professor of surgery, and she joined us from the University of Miami Medical School. Sharon is an expert on sex disparities and has studied disparities in kidney disease and age-related macular degeneration, thyroid cancer, and for the past few years, she's been studying pulmonary fibrosis. She is also the research director of the ILD Center at the University of Miami Medical School. So I'm going to pass the mic to Sharon so that she can tell us a little bit about herself, if she'd like, and the topic a little bit, and then we'll let Dr. Joe Zein start the conversation.
Hi, everyone, and thanks, Ghada, for that great introduction. I just wanted to point out some of the reasons that this webinar is so great, and hopefully we're going to go forward with more on a similar vein. But we need to think about what the physiological differences are between men and women and how that might affect the natural history of diseases and disorders. And what are the mechanisms that might underline these sex differences in susceptibility to certain diseases? Of course, today we're going to hear about asthma and ILD and some others. And why are certain treatment protocols more effective for women compared to men? I think this is really an important issue. Are there sex differences in access to and delivery of care that could affect differences in outcome? And we know that sex hormones play a key role. That's something I've studied for many years. But we also can't exclude the genetic, environmental, and experimental differences that might contribute. And we're studying the biology of sex differences. Undoubtedly, that's going to give us clues to mechanisms of normal biological processes as well as the pathological mechanisms. And finally, I think understanding sex differences is going to ultimately lead to new preventative, diagnostic, and therapeutic practices, which is going to improve health and health care, not only for women, but also for men. I think that's about it.
Okay, that's great. So before I turn the mic to Joe, I just want to ask the audience that if you have any questions, you can send your questions via the chat box that you should see at the right-hand side of your screen, and we should be able to see it. And we're going to take all the questions towards the end of the presentations. So Joe, the mic is yours.
Thanks, Ghada, for this kind introduction, and thanks for the CHESS Foundation for this opportunity. I'm going to be talking about the asthma part. There
you go.
Okay.
Is your mouse working?
I think so, but there's a small lag. Sorry for that. Okay, here you go. So asthma is a inflammatory disease of the airway, usually manifested by chest tightness, wheezing. There's significant gender differences across the lifespan, and mainly in women, and those will give us a significant clues to the pathophysiology and mainly the role of sex hormones. As we know, asthma has a higher prevalence with women who had early menarche, about twofold increase. Also, it's associated with a number of pregnancy in a linear manner, and this may reflect the exposure to female sex hormones. An important entity which is a premenstrual asthma occurring in 1/3 of asthmatic women, associated with significant healthcare utilization. The idea was maybe it was related to an upsurge in progesterone and estradiol in the luteal phase, and there is some data to suggest that there is a protective role for birth control pill in patients with this kind of asthma exacerbation in their premenstrual period. Pregnancy also affects asthma severity depending on the sex of the fetus. So whether the pregnant woman have a female fetus versus a male fetus, as compared to non-asthmatic women, this has been related to differential expression in placental gene. So pregnant women who had a female fetus had about 59 differentially expressed genes as compared to non-asthmatic women, or as compared to asthmatic women carrying a male fetus. Most of those genes have been related to inflammation and immune pathway, and this may explain why pregnant women who carry a female fetus has more severe asthma during their pregnancy. So we're not sure how severe asthma is differentially expressed. So we know that as compared to asthma overall, severe asthma may have a bimodal prevalence. So it's mainly a disease of younger boys and middle-aged women, and this may be related to either direct effect of sex hormone or some interaction between sex hormones and asthma genetic risk variants. So I'm gonna go over a few points. The first one, some epidemiological data. As we know, asthma starts to be more prevalent in younger boys, and after puberty, it becomes more prevalent and severe in women. While the prevalence of asthma distribution, as you see, mainly it's a disease in younger boys, and then there is kind of an eye of the hurricane, and then after it becomes a more prevalent disease in middle-aged women. This graph on the left is taken from the Severe Asthma Research Program, which is an NIH NHLBI multi-center study. This one is SARP 1 and 2, which include about 1,300 asthmatics. One may make the case that this is, a pre-selected group of patients and may not reflect the overall population. The graph on the right is taken from the national inpatient sample, about 53,000 representative sample of hospitalization for asthma as the primary diagnosis in 2012. And as you see, the same graph is mirrored here. So you have a higher peak in younger boys and then in middle-aged women. So as compared to asthma overall, severe asthma has this bimodal distribution. So what happened over the last 15 years? As we see, the prevalence of asthma has been kind of relatively slowly increasing. Fortunately, mortality from asthma has been decreasing over the last 15 years, and still maybe it reflects improvement in asthma care. Unfortunately, mortality in women with asthma has been always almost double the mortality in men. So let's go over a few examples and what happens over the lifespan. The first important step will be puberty. And this is maybe a complicated graph. I'm going to try to go slowly over it. I want to differentiate between boys' puberty and girls' puberty. And girls' puberty, I'm going to divide it in two. The first one to look at androgen-dependent puberty in girls, and that's what we call adrenarche, reflected by pubic hair growth. And then estrogen-dependent puberty in girls, and that's what we call menarche, and this is reflected by breast development. So this data is taken from the Severe Asthma Research Program 3 and includes about 187 boy and girl below the age of 18. As we see, and here we are comparing in a cross-sectional fashion using baseline data, the late puberty, which is reflected by Tanner stage 3 to 5, and early puberty reflected by Tanner stage 1 and 2. As you see, the effect of puberty did not affect lung function, and here either FEV1 or FVC in boys or in girls when we use the androgen-dependent puberty definition. Whereas if we take into consideration the estrogen-dependent puberty definition based on the breast development, puberty is associated with a loss of lung function of about 8% in either FEV1 or FVC in girls with late puberty as compared to girls with early puberty. So this suggests that maybe estrogen has a detrimental effect and is associated with loss of lung function. Looking at the effect of age over the lifespan, and this graph, we're looking at the probability of severe asthma on the y-axis as a function of age. We see that the probability of severe asthma increases with age until we reach about 45 years of age, and then it becomes more plateau. And if we split this by gender, we see that the probability of severe asthma continue to increase in males, whereas it plateaus in women. And this may reflect the protective effect of menopause. We have done a subgroup analysis on patients with severe asthma research program 1 and 2, looking at the effect of menopause, and we found that menopause initially in a non-adjusted analysis was associated with severe asthma with an odds ratio of 5. However, when we corrected for age and age-related comorbidities, menopause was no longer associated with increased risk of severe asthma. This data mirrors also previous published data from the nursing health study that looked at the incidence of asthma in postmenopausal women and found that menopause is probably protective. So more analysis and more research needs to be conducted to look into the effect of menopause. Our thinking was that menopause is maybe protective due to lowering levels of female sex hormones that happens with menopause. So I'm going to go next over the effect of some of the, and correlation basically of sex hormones with asthma severity, and also talk about some, the effect of gene and genetic risk on asthma in both men and women. And also using data from the Severe Asthma Research Project 1 and 2, which include about 1,300 asthmatics, and 40% of those had severe asthma, we found that in men, the lowest FEV1 was seen in men who had low testosterone and low progesterone, whereas the highest FEV1 was associated with higher level of testosterone and progesterone. In women, we found that almost the opposite. So estradiol in this case, high level of estradiol and low level of testosterone were associated with lower FEV1, whereas high level of estradiol and lower level of testosterone were associated with, and high level of testosterone were associated with higher FEV1. Of course, there is some other confounder, and the biggest confounding factor here is age. But even after adjusting for age, we kind of we found the same correlation, that higher estradiol was associated with lower FEV1, and higher testosterone was associated with higher FEV1. The role of DHEA, which is another gonadal, another adrenal androgen. When we studied both patients enrolled in Severe Asthma Research Project 1, 2, and 3, we found that higher DHEA level were associated with higher FEV1. And one may make the case that DHEA is suppressed by the use of corticosteroid, and this may only reflect that those patients were on corticosteroids. When we adjusted for corticosteroid use, we still found the same correlation, that higher FEV1 were associated with higher DHEA, and the idea is maybe DHEA is associated with improved lung function. Our data has been supported by animal data, and here in one of the studies published by Xu, he found that DHEA inhibits bronchial epithelial to mesenchymal transition, and this may reflect a role on lung remodeling. And in this case, DHEA was protective. Another recent data published in Cell have shown that androgen and mainly testosterone has been associated with, so higher testosterone level were associated with lower innate lymphocyte lymphoid cell group 2 proliferation, and this has been associated with less airway inflammation. So also suggesting a protective role and anti-inflammatory effect of androgen, and in particular testosterone. Same thing for estrogen, and the estrogen receptor has been found in almost all inflammatory cells and macrophages, and also increased, this has been related to increased inflammation, increased mucus secretion. Whether the effect of androgen is direct through affecting the DNA in particular and increasing transcription factor, or indirect through other mechanisms like calcium influx, and is still unknown, but it may be probably because of both of those mechanisms. An interesting study, and the only study that looked at genetic effect and stratified by gender, was a study published in 2014. And what they did in this case, so usually when you do a GWAS, you include sex as a covariate and you adjust for sex. So in this study, they did sex-specific GWAS. So they did a separate stratified analysis in both males and females. And they found that there is certain genes were, or genetic variants were seen in males and not in female, and vice versa. We looked at one of those variants, and also using data from the Severe Asthma Research Project 1 and 2, and that particular genetic variant, which is RS2548993, which is related to interferon regulatory factor 1. So this covariate was found in this study to be associated with asthma prevalence in Caucasian and in males. In our case, we found that in not only that it was associated with asthma prevalence, but also it was associated with lower FEV1 in males, but not in female. So that supports the idea that maybe there is some, that either sex or sex hormones differentially affect genetic risk variant effect on lung function and asthma severity. Further study, of course, has to be conducted in this. So in summary, asthma is more prevalent and severe in younger boys, but after puberty, it's more severe and prevalent in women. Gender differences in asthma severity, prevalence, and incidence suggest a role for sex hormone and asthmagenesis. However, this is not easy because this has been confounded by many covariates like age, obesity, atopy, and also environmental exposures. Asthma genetic risk variants confer risk for asthma differentially in male and females. More studies need to be conducted in that perspective. It's very important to understand those gender differences and to help us take care of our patients with asthma and severe asthma. Thank you.
This is great. Thank you very much, Joe, for this wonderful presentation on sex differences in asthma. So next, we're going to go to Dr. Dawn DeMeo. She's going to speak about COPD.
I'm just waiting to get control of the screen.
Okay. Well, while you do that, I didn't introduce Chloe and Andrew, who are on the call with us in the beginning. I'm sorry about that, Chloe and Andrew. Chloe and Andrew are both, they both are at CHEST, and they work very hard with the CHEST Foundation, and they have done an amazing job in terms of women in pulmonary and starting this and getting the funding for it, and we owe them so much. So thank you very much, Chloe and Andrew. And they're helping us with a webinar, so any questions we'll have to ask them.
So thank you very much. Yeah, thank you, Ghada. Thank you so much, Ghada and Sharon. I'm so pleased to be a part of this very important pulmonary webinar series. It's really exciting. And, you know, when we think of lung disease, whether it's COPD, asthma, or pulmonary fibrosis, we really need to think in terms of sex versus gender when we do this kind of work. And sex-related issues refer to those related to the X chromosome, hormones, other biologic influences, whereas the gender-related impacts are really much more complicated in many ways. They include environmental exposure, some of the socio-cultural phenomenon, occupation, diet, and emerging issues related to gender identity and identification. We're not going to have time to touch on all of these, but just to set the stage. So we are really interested in highlighting sex and gender differences related to COPD. Intrinsic to this, of course, would be a deep discussion of the links between tobacco and lung disease in women, and that hopefully will be a topic for a future webinar in this series. But it's really important that we convey that a lot of these epidemiologic implications of sex and gender have therapeutic relevance. And so we'll touch on some of the therapeutic observations that have emerged from some of the decades of research here. But perhaps the most important reason to understand COPD in the context of women is that emerging research suggests that the path to precision pulmonary medicine, whether it's for COPD, asthma, IPF, is going to be through science that really captures sex and gender, both in terms of cause and effect. So if we were to stop this dialogue now, I would want to set the stage for what people should take away. What we understand is that women carry the excess burden from COPD, and that it's younger women that really carry the lion's share of this burden. We know that women experience greater dyspnea for similar levels of lung function impairment. They have greater healthcare utilization. And in terms of therapeutic implications, women may have increased susceptibility to tobacco smoke. Again, we won't be able to touch on that. But women are also overrepresented in COPD groups with treatable traits such as the asthma COPD overlap. We see increased rates of comorbidities, including anxiety and depression. And we really need to think of some of the emerging 21st century threats to the pulmonary health of women when we talk about these sex and gender differences. So for those of us who have been doing this kind of work, this plot, we've studied this and we go back to this again and again. And what this suggests is that if we look at year on the x-axis and the number of deaths from COPD on the y-axis, we saw the inexorable increase in deaths from COPD over the years, but in the year 2000, the number of women dying from COPD surpassed the number of men. And this was the first time this ominous trend was observed, and it was really one of the first strong calls to action. And if we think of what could be the cause of this kind of trend, we understand that there are multiple reasons why people may develop chronic obstructive pulmonary disease, whether they be occupational, asthma related across the life course. But in the Western world, we think of tobacco use. And we know that women are more susceptible. And on a global scale, tobacco is now emerging beyond biomass fuel as a global threat as well. And if we think of the epidemiology here, and we look at the way in which COPD and smoking trends have overlapped, if we look at the solid lines, we see that smoking amongst men and women have declined over the decades, but the number of, the percent of deaths from COPD has continued to rise. So this is another way to show the data that we just studied. And if we think in terms of COPD prevalence, of the approximately 15 million people who have been diagnosed with COPD, about 58% of them are women. And after taking into account the differences between the sexes in age, ethnicity, income, education, and smoking status, women are 37% more likely to have COPD than men. And we know that COPD can take decades to develop, and that the prevalence of disease in women and men continues to increase with age. And women have higher rates of COPD across the lifespan, although they appear to be particularly vulnerable before age 65. And like tobacco use, COPD is a very primarily disease of the poor, and the prevalence rates for both men and women rise as income rates fall. And such this strong link between COPD and poverty, it just adds to the disparity that we see in sex and COPD. And this is really recapitulated here in this recent paper in JAMA, where it is a little bit more recent. If we look at the respiratory mortality from 1980 to 2014, there was an overall 30% increase in respiratory mortality. And the majority of this increase was really portended by the increase of 107% of COPD-related mortality in women. And if we look at these plots, this is men, this is women, looking at the distribution and the change in age-related standardized mortality rates for COPD, we see the highest mortalities in the southern part of the United States, especially in Central Appalachia. Again, this link with poverty and this disease and some of the sex disparities. So if we think of some of the drivers of sex differences, it's really important to think in terms of bias. And this is a really wonderful paper by Chapman, which presents a case. And this case suggests a hypothetical patient that was given as a presentation to 192 primary care physicians. And the only thing that wasn't initially presented in this case was the gender of the individual, an ex-smoker, 40-pack years with a chronic cough and exertional dyspnea and wheeze. They varied the gender and the age and variably introduced spirometry. And based on the history and physical, only 49% of women were given the correct diagnosis of COPD versus 65% of men. And this was repeated in a European study suggesting that this was not just a phenomenon of US studies. So bias is one issue to consider. And then if we ask women themselves, what do you experience? Women are more likely to report diagnostic delay, difficulty reaching their physician to discuss their symptoms related to COPD, inadequate physician time, less receipt of education. So together with a potential bias of not getting the right diagnosis, women don't feel as engaged in their care. In terms of comorbidities, depression and quality of life are really important aspects of COPD multidisciplinary care. We know that there's a higher prevalence of anxiety and depression in women with COPD. And because we know that the risk of COPD-related rehospitalizations are informed in patients with anxiety and low health status scores, treating these comorbidities in a sex-sensitive fashion are really crucial to our work as pulmonologists. If we think in terms of subtypes of COPD, one important subtype, because of age-related issues, is the early onset COPD subtype. And what we know is that across all age groups, women, younger women, seem to have the higher percent of early onset COPD. And so out of that research also suggests that for every cigarette smoked, women have more severe COPD at an earlier age. Why this may be the case could be anatomic, smaller lung size in women, some chromosomal or hormonal issues. There may be complex interactions with aging in the lung, but there probably is some complicated molecular interaction with sex and gender that we really need to put a focus on at the national level for research. Another subtype we talk a lot about is emphysema. There was a wonderful study in 2007 that integrated the study of sex-specific and gender-specific manifestations of COPD with emphysema and CT scans. Overall, women demonstrated less overall emphysema, especially in the periphery of the lung, and they had thicker airway lumens on CAT scan. And this raised this question in the field: was emphysema just a phenotype of men? This was followed up by a study that suggested no. If we look on average, if we look at a population and look stratified by sex, men, represented by bars on the left, versus women, on average had more emphysema. But if we look at subgroups such as the early onset or individuals with the most severe emphysema or the highest gold stage, then we saw absolutely no difference in the percent emphysema, suggesting that this subtype is not just a subtype of men. And then if we think of a third important subtype, the asthma COPD overlap syndrome, this is something that many of us have seen clinically, this overlap of features of asthma with irreversible airflow limitation. There's clinical implications for identifying ACOS because it is potentially treatable, treatable trait including eosinophilic COPD. The ACOS syndrome is associated with more symptoms, more exacerbations, greater healthcare costs. It's been poorly studied, but it is also a female predominant subtype. So again, more emphasis here on the comorbidities and the overlap. So if we bring it all together, this is a beautiful article that was in Chest last year that really integrates tobacco, occupation, non-occupational exposures, but really important in the care we take of women. We need to really act in a multidisciplinary way to make the right diagnosis, to bring together all aspects of care, and being mindful of the role socioeconomics play in sex and gender differences in COPD. The therapeutic implications, COPD studies have generally not been powered to study sex differences. There have been some early studies on inhaled steroids, but really until recently, two recent studies that have tried to address this. This is from a post hoc analysis that looked at ipratropium bromide responsiveness, suggesting sex differences in bronchodilator responsiveness. But we have a whole host of ways in which sex differences have not been studied in terms of COPD therapeutics. And again, another call to action is needed. So when we set a clinical agenda, we really need to suspect COPD in women. We need to actively treat nicotine dependence. We need to address quality of life, depression, comorbidities, coping strategies, pulmonary rehab, nutrition, many, many issues that we don't really think much about varying by a sex-specific way. If we think of what kind of partnership we need to have in taking care of women with lung disease, we need to educate at the earliest levels. We need to engage women in social media platforms like the COPD 360 COPD Foundation campaign. We need to really improve our public health messages. We need to be sex-specific in smoking prevention and smoking cessation, and develop these partnerships from research to legislation to get these sex-specific messages for the care of women with COPD out into the mainstream. In terms of emerging concepts, we really need to be mindful of the exposures of millennials and the sex-specific threats to lung health of e-cigarettes. We need to be aware of the changing face of COPD, including young and transgender women. Sex minorities are very frequently underrepresented in pulmonary care. We need to think of subphenotypes that have sex differences, including the ACOS syndrome and early onset COPD, thinking in terms of treatable traits and the role of hormones in sex-specific therapeutic studies. But really, we need to transition pulmonary care of all women from reactive to predictive, personalized, preventive, and participatory P4 medicine for all women with COPD in the 21st century. Thank you so much.
Thank you very much, Dawn, for this lovely overview of COPD in women and looking at sex and gender differences. So next up is Dr. Danoff, and she's going to be speaking about differences in interstitial lung disease. Thank you, Sonye.
Thank you. Well, first I want to thank the CHEST Foundation for really putting in the effort to shine a light on the fact that we often think about pulmonary disease in a gender-neutral fashion, and that's probably not correct. And so I also want to thank the speakers who came before me, Joe and Dawn, because they've really set up a beautiful framework for how to think about sex and gender and the impact that it can have on disease presentation and management. Next slide, please. What I'd like to do is just remind all of you that interstitial lung disease really describes a group of diseases. Perhaps the fact that we've talked about some of the subcategories of asthma, like the severe asthmatics, and the different subcategories of the COPD, including ACOS and early presentations, really sets this up nicely. What we're really talking about is a whole collection of diseases that affect a potential space, an area that really shouldn't have anything in it, that's at the interface between the alveolar and capillary components in gas exchange. And what we describe as interstitial lung disease really includes probably 100 or more separate diseases, which are simply have in common this inflammatory and or fibrotic process that affects this incredibly critical component in oxygen absorption. Next slide, please. And so when we think about sort of the scope of interstitial lung disease, we're really not talking about a single disease. We're talking about many, many different and distinct diseases. And I point this out in part because the role of sex and gender is actually much more complicated in the interstitial lung diseases, largely because of this rather broad array of diseases that fall into the category. So you can see that there are some interstitial lung diseases where we recognize what the etiology is, so connective tissue diseases, drugs, occupational exposures, but the majority of diseases of the interstitial lung disease are really idiopathic. That is, that we don't fully recognize what causes the etiology. That said, it is likely that there are some distinct etiologies which contribute to these diseases, and that probably is associated with some of the gender and sex differences that we observe. Next slide, please. So if we were to break this down into a couple of different categories, you can really see that depending on the form of interstitial lung disease that we're discussing, the sex differences could be entirely one direction or another. So perhaps best known is amongst the connective tissue associated interstitial lung diseases. There's a female predominance of about 2 to 1, but that doesn't hold true if that connective tissue disease happens to be rheumatoid arthritis. So even within that category, there's a difference in terms of the prevalence of interstitial lung disease. Certainly some interstitial lung diseases like LAM are essentially only in women, sporadic LAM. Whereas other interstitial lung diseases, perhaps most importantly, idiopathic pulmonary fibrosis, is reported to have a 2-to-1 predominance of men to women. Now, the interesting issue here is that if you look at recent clinical trials in idiopathic pulmonary fibrosis, four to one, not 2-to-1. So either we don't understand the epidemiology of the disease fully, or we don't recruit a group of patients who are truly reflective of the disease as a whole. And similarly, you can see some diseases like RB-ILD, respiratory bronchiolitis, interstitial lung disease, and pulmonary Langerhans cell histiocytosis, in which males and females have equal prevalence. Interestingly, both of those diseases are actually smoking-related diseases. So again, this really points out that within the interstitial lung diseases, there's a huge amount of heterogeneity. There's probably some distinction even within small subcategories of interstitial lung disease. And often the clinical trials that we run may not be fully reflective of the numbers we think are associated with those diseases. Next slide, please. So not only does sex impact the prevalent, not only is sex involved in the prevalence of disease, but it actually impacts the experience of disease. And this really harkens back to some studies that Dawn was discussing as well, where on the y-axis you see increasing dyspnea, and on the x-axis you see the change in lung function. So, you know, one might predict that there would be the same degree of impairment or change in sense of dyspnea for a change in lung function for men and women. But in fact, women perceive dyspnea at a much lower level of DLCO impairment. So women have a symptomatic difference for an equivalent physiologic difference. And this is also seen in some of the other studies. This is a very nice study by Meilan Han and colleagues looking at gender influences on quality of life. Next slide, please. So this actually looks at, in the same population of patients who have IPF, at the way the degree of dyspnea impacts both sense of physical well-being and mental well-being. And what you can see is that there's a very distinct difference in terms of the way this impacts men and women. So for women with increasing dyspnea, there's a much more significant impact on the mental health composite score, whereas in men, it's a more significant impact on the physical health composite score. So not only do men and women have differences at the same physiologic level, but they also have it translate into a different degree of impact on quality of life. Next slide, please. Now, ultimately, one of the big questions that we come to is whether sex impacts survival. And interestingly, in interstitial lung disease, there's really been very little convincing data one way or the other as to whether sex impacts survival. Clearly, there are certain interstitial lung diseases which confer worse survival, but within the same disease diagnosis, it's really unclear. There have been studies showing both that female sex conferred advantage or disadvantage in patients with a definition of IPF, a diagnosis of IPF. And so clearly, even within one group, it's somewhat unclear whether there's a benefit. Interestingly, there was a relatively recent study looking at lung transplant. And the question was whether men or women post-lung transplant, all of whom had IPF and were greater than 65, which is typical age of IPF disease, whether there was an advantage for men or women. And as you can see in this graph, which is a survival curve, there is a slight advantage that appears to convey to women over time. But obviously, this is a fairly small advantage over time in a fairly unique population of people, namely women over 65 who have IPF. Nevertheless, I think that what this suggests is that there may also be features that are integral in survival that have something to do with sex or perhaps gender. Next slide, please. And so let's just go back around to this question of what are we thinking about when we think about sex differences versus gender differences. Next, please. So with sex, next, please, the issues that we really are thinking about are essentially biological issues. As Dawn mentioned, things related, as both Dawn and Joe mentioned, things related to sex hormones, but also I would add into that the impact on autoimmunity. And when we think about gender, next please, we think about the environmental issues, the issues of choice, so exposures like smoking and occupational exposures. But I would also go back to the same point that Dawn made, which is I think that a very important piece we need to think about is ascertainment. So when a woman comes in with a cough and shortness of breath, how long does it take to think that that patient has interstitial lung disease in comparison to a male of equivalent age with the same symptoms? And I think that the next step is to think about how a patient's gender or sex influences their experience of their disease. And then lastly, I think one of the issues that we're going to be exploring as we move forward is looking at how a person's gender impacts the therapies that are suggested to them. Clearly in IPF, there are new therapies that are available. In many of the other diseases, we use off-label therapies. But again, I think that we need to look at whether there are some unrecognized biases that lead us to make decisions about therapy. And with that, I will thank all of my colleagues and CHEST and our moderators for allowing me to participate in this discussion.
Thank you very much, Sonye, for this wonderful overview of ILD. And again, thank you to all the speakers. So now we're going to take any questions. Chloe, are you on?
Yes, and so far we actually have not received any questions yet, but one of the questions that came up is what I noticed in this presentation. In almost every single one of the disease states, and actually I think every single one of the disease states, we're really showing that there's quite a significant difference in the mental health score that women are reporting. And what I was wondering is, what do we do to address that specifically, not both from the clinician side of things, but also from the patient side of things? And I was curious if we could talk on that a little bit.
I mean, this is really a wonderful way in which we need to educate our patients that there are a lot of opportunities for support, whether it's Better Breathers clubs or online support groups sponsored by the COPD Foundation, for example. And I think the availability of the internet has really opened up a whole new possibility for people to find support in like-minded individuals. So I think there's an opportunity to not only, be clinicians and treat our patients, but to point them at ways they can become self-advocates.
That's great. So I have a question for Joe and anybody else who wants to answer this. So Joe mostly talked about estrogen and progesterone and testosterone and those potentially leading to gender differences. So I have two questions as it relates to that. One, are endogenous and exogenous hormones similar? So, and we've talked about gender and sex. So with gender differences and transgender individuals, we might be facing more exogenous intake of these hormones, whereas with life cycles and hormones changing during a woman's life cycle, we may see more of these endogenous hormones changing. Are the effects of these different? And, let's start with this, and because my other part of the question is completely different. So, Joe, if you want to take this, or if anybody else, Sharon, maybe if you want to comment on that as well, that would be great.
Maybe I can start and Sharon can follow. The quick answer is no, unfortunately. And there is
No,
many.
you don't know, or no, there's no difference?
We think they are different. So the role of exogenous hormone is different from the endogenous hormone. So there is one published study on transgender from I think either Norway or Sweden that looked for the effect of hormone supplementation on lipid level. And they found that so both of them increase the risk of heart disease. So you expect that estrogen is protective and androgen are not protective. So those were transgender patients. And so the odds ratio of having heart disease was 2.5 if they got estrogen and 3.5 if they got androgen. The same thing with asthma. We also looked at transgender receiving and the risk of the prevalence of asthma. Also, we found the same thing. So you would expect that if someone is getting androgen, the risk of asthma is lower. We found an odds ratio of 2.5 and an odds ratio of 3.5 if they were receiving estrogen. You know, whether you're a male to female or female to male transgender. So this is, and there is lots of, there is one, I think there is some studies on macrophages and the same thing that they found a completely different. So just expecting that androgen are protective and estrogen are not protective in asthma may not be true whether this is an endogenous hormone or an exogenous supplementation, if that makes sense. So the quick answer is probably they're not the same.
I can speak to that on the kidney at least. We actually looked at inappropriate amounts. Can you guys hear me?
Yes.
Oh, inappropriate amounts of testosterone for a female, which would be perfectly normal in a male. These were in mice. But we did find that the amount of testosterone we gave to female mice triggered glomerulosclerosis, where the male mice were fine. So I think we're going to, and there aren't so many studies yet on transgenders, but I think as time is going on, we are going to see, and I think that's what you were saying, Joe, is that it depends on how much you're taking and who you're giving it to.
Right.
Right. Absolutely true.
We have a few questions coming in from the audience, so we'll go ahead. If it's okay with you, Ghada, I'll ask
Sure.
some of those that are coming up. So for the panel, are there currently studies in process regarding the effect on transgender patients with COPD currently taking HRT?
Hormone replacement therapy. Dawn, are you aware of any?
I am not aware, but I do know that there are several research groups pursuing these kinds of studies. But I was just actually looking up that very question on the internet as it came in, and I'm not familiar with any right now. But we could take that question offline and do a more thorough answer to that question.
Okay.
Great.
That's great.
The next question is, does the external testosterone influence asthma control? For example, TRT.
Nobody knows that.
So Joe, you want to take that again?
Yeah, very interesting question. Actually, one of the studies we were planning to do is testosterone replacement in older men who have already a low level of testosterone. To my knowledge, no one ever, I think, looked at this question. The other one will be also to supplement DHEA for patients with severe asthma. Probably that would be either men or women. We don't know the answer, and hopefully we will know. And the fact we start thinking about asthma or COPD or interstitial lung disease from a sex difference perspective is basically to look into the effect of hormonal modification and their impact on disease progression. Hopefully soon we will have an answer for this, but I'm not aware of any study that looked into that.
Okay, next we have where, and I know we addressed the disparities a little bit, but in terms of where it falls in terms of racial disparities, where does healthcare disparities fall in your presentations in regards to COPD, asthma, and ILD, especially when comparing African American women or minority women concerning those disease states? And that's probably a very large question, but I mean, if there is one thing that you wanted to say on that topic, because I know that could probably be a full webinar in of itself.
Well, I think with regard to COPD, as clinicians, as providers, we're very concerned about this issue of disparities by sex and race. And we do see that the occurrence of severe early onset COPD, we do see that African American women with a history of smoking are very strongly represented in that group, and the reasons are likely multifactorial, as we discussed earlier. But I think this idea of dual disparities is a very important one, at least for COPD.
And I would say that that's also true in interstitial lung disease. I think that particularly in the connective tissue disease, ILD, we've been very struck by the importance of both race and gender in terms of the time to diagnosis, as well as the sort of access to medical care and therapeutic decision making. So, while we don't have an answer, I think that that's an incredibly important question that we need to continue to look at.
Just briefly, for the asthma perspective, there is definitely racial discrepancies. And even the only thing I want to say, even taking those racial discrepancies into consideration, luckily, the mortality also has been coming down across all races. And the other thing I want to point is that this bimodal distribution of asthma being a disease in the younger boys and middle-aged women was, exactly the same, regardless of what your race is, Asian, African American, or Caucasian. So there is some discrepancy, but the gender variation in asthma is probably the same.
Okay, I think we probably have time for one or two more questions. The next question is, are there any acute differences seen in any of the disease states in women while they are experiencing ovulation menstruation? For example, are they at an increased risk for exacerbations of asthma, COPD, or IPF?
Maybe I will start. In asthma, we have this premenstrual asthma and occurring in 1/3 of women and resulting in a high number of healthcare utilization. This may be related to fluctuation in sex hormones during the luteal phase. So in asthma, it's a very well-described phenomenon. So that's just to explain that.
We notice this less in interstitial lung disease, but we do notice very significant changes in both risk of development of disease as well as in disease control during pregnancy, where pregnancy obviously exacerbates the restriction in the lung disease. And so it's often a very high risk period for our patients with interstitial lung disease.
And with regard to COPD, just given the age distributions, many of the women with their first diagnosis of COPD are postmenopausal, so less of an issue.
Right. This is great.
Yeah, and I think that's probably all we have time for question-wise.
So I have one more question that I wanted to talk about, and I'm curious about the effects of sex hormones again. So in terms of say asthma or, other conditions, mostly for asthma, given what we know about the interaction of severe asthma with body habitus, for instance, do we know that the effects of hormones, is that like a direct effect of the hormones, or is that as hormones change throughout the life cycle, body fat deposition and fat distribution is in certain areas, and is that what really impacts asthma severity, or is it more through, say, estrogens are changing and estrogen can upregulate inflammation like you talked about, Joe? Like, I'm not really sure if that's a direct effect of hormones or not, and maybe we don't even know the answer to that. But I find it very interesting that some of these things go hand in hand. We just don't know what is the direct effect on lung function or disease severity and disease, natural course.
This is a very, very difficult question and a very good one too. I think it's both. There is no doubt that obesity is contributing, and the peripheral conversion of androgen into estrogen and so forth. There is some data looking at hormonal replacement therapy in postmenopausal, and the effect or the impact was different whether the patient was obese or not obese. If I want to, if I want to summarize this, it's probably both. I will be surprised to relate everything just to obesity. All the analysis that we did at the clinic, we always adjusted for obesity, and we also stratified by obesity, and we still found that asthma was related independently to alteration in sex hormones. So just very briefly to go over 3 studies which we stratified by obesity was the prevalence of asthma in patients who have diseases that we thought were related to hormonal disturbance, like polycystic ovarian disease, and also hormonal, those who are getting oral contraceptives, or also those who have endometriosis. And what we found is, regardless of what is your obesity and body weight, body mass index, hormonal disturbances were associated with higher prevalence of asthma. So it's a very difficult question, and that's the challenge, is how you're gonna adjust for obesity when you look at gender differences. But I think it's probably both.
Great. All right, so it is 4:02. We are 2 minutes past our time. I thought it was a wonderful webinar. I hope our attendees thought the same as well. Again, I want to thank the Chest Foundation and the supporters who have made this possible. And I would like to remind all of the attendees that these programs happen because of the Chest Foundation. So I would like to encourage everybody to donate whenever you can. The Network's Challenge Giving Month is now. You can donate throughout the year. If you're interested in women's topics, you can do that through the women's topics, specifically through the Women's Health Network, but any support of the Chest Foundation would be great. We have given so many I have received 2 grants through the Chest Foundation, and they helped me tremendously, and I'm sure many other people have taken advantage of it. So I want to call on everybody to help when they can. And Sharon, any last comments?
No, I thought it was a wonderful group of panelists, and hopefully we can do this again.
That's right.
Great. Thank you, everyone. Just want to say thank you. Oh, go ahead.
No, I just wanted to say thank you to both you and Andrew, because you have been a pleasure to work with.
Thank you, Ghada. And I want to say thank you to all of our panelists and our co-moderators. We really appreciate having you on today. And then just a reminder for everyone at the end, there will be a very quick survey, and that helps us in identifying what it is you want to learn about and what we can provide to you. So please take an extra 2 minutes and fill out that survey. And thank you again.
Great.
All right.
Thanks, everyone. Have a good week.